Okay, thank you for the introduction, and I would like to thank the organizers to invite me to talk about the micronutrient intakes and health outcomes in preterm infants. And what is micronutrients? Well, it's actually all nutrients except the macronutrients, protein, fat, and carbohydrates. So that includes all minerals and vitamins, and also nutrients like LC-PUFAs, which I will come back to. And it's important to realize that micronutrients can have very drastic health impacts in preterm infants. Here we can see on the left a massive intracerebral hemorrhage due to vitamin K deficiency. And in the middle you can see here progressive ECG changing by increasing levels of hyperkalemia, which of course is life-threatening. And on the right-hand side you can see a humeral fracture due to calcium and phosphate deficiency, which is common in preterms. I will come back to that, and which also can be caused, of course, by vitamin D deficiency. But it's important to realize that micronutrients very often have much more subtle impacts, but which are nevertheless very, very important for preterm infants. And these are effects on growth, on retinopathy or prematurity, and not least on brain development. And we have used iron as a model nutrient to study the effects of micronutrients on brain development. And as you know, iron is essential for several aspects of brain development, such as myelin formation, monoamine synthesis and function, neuronal and glial energy metabolism, and neuronal growth and arborization. And we performed a randomized controlled trial in low birth weight infants. These were 285 otherwise healthy infants with a birth weight between 2,000 and 2,500 grams. 50% of these were preterm. And the intervention was iron drops at 0, 1, or 2 milligrams per kilo per day. So 0 would be the placebo from 6 weeks of age until 6 months. And at 6 months, we observed that the iron supplementation resulted in very much lower incidence of iron deficiency and iron deficiency anemia. You can see here there was virtually no iron deficiency anemia in the 2 milligram group, but it was 10% in the placebo group. But what is interesting is not only the effects on these biomarkers, but on the actual health outcomes. So we studied these children at 3 years, and we found that there was quite a clear effect on behavioral problems. The placebo group had almost 13% behavioral problems, while those who received iron supplements, which are the two next bars here, the two striped bars, had less than 3% behavioral problems, which was similar to a control group of children who had normal birth weight, which means no increased risk of iron deficiency. So in this case, we show that iron supplements significantly reduced behavioral problems, illustrating the increased need for iron in low birth weight infants. And this effect remained at 7 years of age when we followed the children. You can see here, and this here, the effect was mostly seen in externalizing behavior. On the other hand, we have to remember that it's important to avoid iron deficiency in order to improve neurodevelopment, but we also have to avoid toxic effect of iron overload. And this is especially important for iron because we have no mechanism for excretion of iron from the body, and it's a highly reactive pro-oxidant. And also iron is an essential nutrient for many pathogens. So it has been described that iron overload can result in increased risk of infections, diarrhea, poor growth, and even poor neurodevelopment, suggested in at least one study. And we have also seen recently it has been discovered that iron also can give dysbiosis of the gut microbiome. And we showed this in a trial with 72 healthy iron-sufficient non-anemic 6-month-old infants who received iron drops or high iron formula or a low iron formula during 45 days. And we observed that a clear effect of iron on the gut microbiome, most prominently in the iron drops group. which had less lactobacillus and streptococcus and more Clostridium and Bacteroides. So this effect of the microbiome could lie behind some of the adverse effects of iron. Also, it's important to realize that local practice regarding blood sampling, blood transfusions, and EPO treatment, of course, very much influences iron requirements in very low birth weight infants treated in neonatal units. We recommend the use of ferritin, which is a good measure of iron status also in preterm infants. And this is a study done in a center with a quite liberal transfusion practice. And we can see here on the y-axis, we have log values of ferritin. So you can see that some of these ferritin values are really, really high, but we also have some low ones. And we see that it's clearly related to the dose of blood transfusions that the infants received. Now I will skip to sodium. And I think you all know that hypernatremia is very common in very or extremely preterm infants during the first days of life. And we can see here a clear peak of sodium on day 3. And then the average sodium levels go down here, plasma sodium. And after the first week, hyponatremia is actually the more prominent problem in these babies. And this is because poor reabsorption of sodium in renal tubuli causes sodium losses in the urine. So because of this, it's recommended to have a very low sodium intake during the first days. And then after day 4, we recommend a much higher sodium intake of 3 to 7 millimoles per kilogram per day. And this usually or frequently, these babies will require sodium supplements. It's important to realize many people think that these hypernatremia during the first days of life is mostly due to sodium given with parenteral nutrition. But as you can see here in the leftmost bar, actually in this study, only a very small proportion of the sodium given during the first 3 days was from parenteral nutrition, and most was actually from blood products through flush solutions, medications, and saline infusions. So it's very important to remember to minimize those sources of sodium in the first 3 days. And this is some unpublished data from our group where we investigated the effects of a parenteral nutrition solution without having a special low sodium and potassium concentration during the first 3 days of life. And we can see here when we gave 2 millimoles rather than 0.7 millimoles per kilo per day from parenteral nutrition, and also a higher level of potassium, 1.2 versus 0.5, we actually observed no difference in hypernatremia, as shown in the top figure here. And we did observe more hypokalemia with a lower potassium intake, actually here, 76% versus 30%. So these results suggest that there might not be a need for a special low sodium and potassium solution during the first 3 days of life, and that really we should maybe increase the lower limit of the recommended potassium recommendation from 0 to 1 millimole per kilo per day. So now I will skip to phosphate or phosphorus. And early hypophosphatemia is very common in very low birth weight infants during the first week of life. It may be life-threatening, and the risk factors are small for gestational age babies, and especially with a high amino acid supply with inadequate phosphate supply. Hypophosphatemia is usually defined as less than 1.5 millimoles per liter, and severe hypophosphatemia less than 1.0 millimoles per liter. And this is not a phosphate deficiency, it's a shift between fluid compartments. So as seen here, if we give parenteral nutrition with amino acids, these will be transported into the cells and bringing with them into the cells phosphorus and also potassium, and the lower phosphorus in plasma will cause a release of calcium from bone tissue. So these early hypophosphatemia very often is associated with hypokalemia and hypercalcemia, and in many cases also hyperglycemia. So it's important to check for these early hypophosphatemia because it can be severe and it can even be life-threatening. However, the late hypophosphatemia, which is common in very low birth weight infants after 4 weeks of life, is associated with osteopenia and deficiency of both phosphorus and calcium. And so if you have a low phosphate level, you should also check alkaline phosphatase, which is usually increased in these situations, and you should do an X-ray. And importantly, calcium levels are not useful to screen for this osteopenia, because the calcium levels are usually normal or even elevated. The highest risk of osteopenia, even with fractures, is seen in infants or preterms on long-term PN, especially those that have undergone abdominal surgery, and they might also be treated with steroids and diuretics. And treatment and prevention include adequate phosphate and calcium supplements, and of course vitamin D. Now I will mention long-chain polyunsaturated fatty acids. As you know, there are two versions. These the omega-6 fatty acids, exemplified here by arachidonic acid, and the omega-3 series, exemplified here by DHA. And really, humans can produce these from linoleic and alpha-linolenic acid, which are very common in the diet. But we think that preterms especially have an immature delta-6 desaturation activity, and therefore might need extra arachidonic and DHA. LC-PUFAs are essential for normal brain and eye development. It has been a lot of research in this area since the 1990s. Most studies have focused on DHA. Some studies have shown a positive effect on visual or cognitive development in term infants. Even though the jury is still out, I would say, on term infants, but in preterms, suggested health benefits have been suggested on brain development and reduced ROP and BPD. LC-PUFAs are present in breast milk, but they are highly dependent on the mother's diet. We know that postnatal deficiency of DHA and arachidonic is common in extremely preterm infants. We can see here from a Swedish study that the serum levels of DHA and arachidonic acid drop quite a lot during the first week of life, and this is regardless whether the babies get intravenous lipid emulsions with these fatty acids. So enteral supplementation has been suggested, and this is an Australian study showing that, or the hypothesis in this study was that DHA supplementation would decrease the risk of BPD. However, on the contrary, it was shown that there was a significantly higher risk of BPD in the group supplemented with DHA. So, but it's important to realize in this study they did not use any arachidonic acid, and it might be so that you need to have a balance between these omega-3 and omega-6 fatty acids. So a very recent Swedish study where 101 extremely preterm babies randomized to either a combination of DHA and arachidonic acid or placebo from less than 3 days until term age. And here we showed that the supplemented infants had a 50% reduced risk of ROP, which is very interesting, I would say. And we are now awaiting the result of a similar study underway in Norway, in Oslo, where 120 preterm infants less than 29 weeks receive almost exactly the same intervention as in the previous study. The primary outcome here is brain development as assessed by MRI at term age, and the first preliminary results are expected in the fall of 2021. So where can we get advice on recommended intakes of micronutrients? Well, the European guidelines, the ESPGHAN, ESPEN, ESPR guidelines are from 2018 are available, and they are for children at all ages, including preterms. So this is quite good information for preterms. And what about the enteral? Well, we have these ESPGHAN guidelines from 2010, but they are actually being revised right now. And this is from an author group meeting in February 2020, right before the pandemic. And this paper will include lots of sections, and several of them will discuss micronutrients. And I would just give some examples of what will come out in these new guidelines. Vitamin D, we know there's a huge research interest, but there's a lack of well-performed studies in preterms with clinical outcomes. And bone health is actually the only evidence-based clinical outcome, but there is no clear evidence that higher doses than about 200 to 400 international units per day improves bone health. And the previous dose recommendation was 800 to 1,000 international units per day, not per kilo. Almost all studies performed in infants are performed in infants with weights around 1,500 grams. So very little is done on the smaller preterms. So, and for a 500-gram infants, if you give 1,000 international units per day, that's 2,000 international units per kilogram per day. And the safety of this is really not shown. Possible adverse effects of too high doses of vitamin D include nephrocalcinosis. So the new recommendations, which are evidence-based, are now lower than the previous, and importantly, they are framed per kilogram per day, which is similar to all other nutrients, not just per day, but per kilo per day. So the new recommendation will probably be 400 to 70 international units per kilo per day, up to a max of 1,000 international units per day. And this table shows what the results will be in different weight categories. So you see here for 500 grammers, it would be 200 to 350 international units per day. And for a 1,500 gram baby, it would be 600 to 1,000 international units per day. And the old recommendation was 800 to 1,000. So slightly different vitamin D recommendations. Zinc is another important micronutrient. It's important for growth, immune defense, wound healing. You can see here a picture of the typical rash you can get with a zinc deficiency. We have no toxicity problems like with iron. The traditional fetal accretion calculations are based on preterms in the range of 1,500 to 2,000 grams, but infants with a weight less than 1,500 grams would then theoretically have higher needs. A randomized controlled trial from 2013 suggested a zinc intake of 6.6 milligram per kilo per day compared to 0.9, reduces neck and mortality. Of course, this needs to be confirmed, and this is a very high intake, which is higher than the estimated requirements. A recent Cochrane meta-analysis published this year showed that zinc supplements for preterm infants may decrease mortality and probably improves weight gain and linear growth. This Cochrane analysis included some different notes, including this trial from 2013. So overall, weighing in all this evidence, the new ESPGHAN recommendation is higher than the previous. We now recommend 2 to 3 milligrams per kilogram per day, and the old recommendation was 1.1 to 2 milligrams. Please observe that these recommendations that I just mentioned are not finalized. All recommendations will go through a Delphi procedure requiring 80% consensus. We aim to have these new recommendations published in the end of this year in JPGHAN. So how do we keep track of all micronutrients? Many clinicians, we know, they feel that the micronutrients, they are bothersome and they are complicated and there are too many of them and everything is very difficult. But I would just have some important points to remember, take home message. What about checking micronutrient status? Well, I would suggest that you remember to check serum phosphate to check for this early and late hypophosphatemia, and also that you check serum ferritin at least before you start giving iron supplements. And then also remember that assessment of vitamin and trace element status is really tricky. It's quite unreliable in infants with ongoing inflammation, and there's a very good review paper published last year from the ESPGHAN Committee on Nutrition on this topic. We do have guidelines. We know the recommended intakes, and there will be updated guidelines, as I mentioned. But then you really need to have computer support for prescription, and there's some really good software out there. We have developed this software, for example, to show not only the macronutrient intakes but also the micronutrient intakes. So this is an example, a 25-weeker, 700 grammer, 7 days old, and the prescription here contains mother's own milk and a parenteral nutrition solution. And you see that this combination gives a very good fluid intake, energy intake, protein, amino acid intake, carbohydrate, glucose, and lipids intake. So all the macronutrients and fluid is perfect. But then if you look at the micronutrient intakes, they are not very good at all. A very low sodium intake, low calcium, phosphorus, magnesium, and very low trace elements and vitamins. So here is the same prescription, but it has been added vitamins to the parenteral nutrition solution and also trace elements. It has been added half dose multi-nutrient fortifier to the breast milk, and on top of that some multivitamin drops and some extra calcium and phosphate supplements enterally. So here we see we can achieve a good intake also of the micronutrients. So in conclusion, micronutrient intakes have crucial short and long-term impact on health outcomes in preterm infants. That's a lot of ongoing research. It's a hot topic, and recommendations are available for parenteral and enteral intakes. And please remember to consider micronutrients when prescribing nutrition. So thank you very much for your attention, and I would like to thank all my co-workers and our research funding agencies. Thank you very much.